So this is a lecture. Okay, Bismillah Rahman Rahim. Assalamu alaikum, everyone. Sorry for the audio problems. So this lecture was given to me last night. I hope I can do the good things. There's a problem, still some problem. It is going itself. So there are three main lectures in one lecture. So we'll be a bit fast, and there may be some thing which we may miss, or we can cover it tomorrow also. So the objectives are very clear. That main thing is about the atheroma or atherosclerosis, its pathogenesis, staging, and relationship with hyperlipidemia and complications, etc. Then we do the myocardial infarction, which is because of atherosclerosis. So I think I have to leave this field. The slide shows creating problem. Should not do now. Okay, so myocardial infarction is the number 2 topic here, number 5 here, and then finally we'll do the thrombosis and embolism. So atherosclerosis, as you can see in this picture, this is the blood vessel showing these yellow things which are blocking the lumen of the blood vessel, which will cause myocardial infarction. This is just a start. The definition of atherosclerosis is the development of a plaque. This is how we pronounce it, plaque. Some people, they pronounce it plaque also, but I have seen correct pronunciation is plaque. It is the formation of this plaque, which is composed mainly of fat, cholesterol, and inflammatory cells. This plaque is formed in the arterial wall of the arteries, starting from intima. It is an intima lesion. See, this is the normal histology of the blood vessel. The innermost lining is intima, then media, and then adventitia. Okay, those are three layers. So it starts in the intima, just under the endothelium, and then if it becomes large, it can go into the media or it can go into the lumen, depending on the size. It is also called atheroma. It is also called atheromatous plaque. It is also called atherosclerotic plaques. They invade the lumen. They cause the gradual narrowing of the lumen of the blood vessel, and sometimes they can get ruptured to cause complications, which we will see now. Another term is arteriosclerosis. This is different from atherosclerosis. These are two different things. Arteriosclerosis is a journal term, means thickening or hardening of the blood vessel. Hardening or thickening of the blood vessel is called arteriosclerosis. Atherosclerosis is more specific. It has special changes which we will see. Arteriosclerosis can occur in hypertension, diabetes, and other conditions. So they are two different things. This is the diagram of the plaque. It has two main parts: fibrous cap on the top and necrotic center. The top is the fibrous cap, which contains the smooth muscle fibers, the endothelial cells, and macrophages. These are the macrophages. And when they take in the fat, they become foamy macrophages, foam cells. Then there's collagen. There are other things also. See, these are also in the cap. In the center, necrotic center, we have the cell debris, the product of the cells which are dead. Cholesterol clefts. These are cholesterol crystals. These yellow long things are the cholesterol crystals. Then, of course, the macrophages, when they eat the fat, they become foamy. They are called foam cells because they contain the yellow fat in it. And after some time, you will see the calcium is also deposited. These are the calcium deposits, calcification. Is it okay? I'm going correctly? Speed is correct, or you want me to go slow? Please.
No, it's okay.
No, it's fine, doctor.
Thank you so much, because some people may not understand that I can go slow also. We have 2 hours. Don't worry, inshallah. What are the risk factors? This atherosclerosis is the cause of heart disease, which is the #1 killer of the world population. Most important, very dangerous disease. It is so important. It is the #1 cause of the mortality and morbidity all over the world, especially the Western world. So it has risk factors which are divided into two parts. Non-modifiable, which cannot be changed, they are in the constitution of the person, the genes, the genetic abnormality, the family history, the age. As the age increases, the risk factors, there are more risk of developing atherosclerosis. Males are more at risk than the females, only in the beginning. After menopause, male and female, they have the same risk factors. So these are the unmodifiable. But people can modify their risk. They can change by eating properly and changing the lifestyle. Like hyperlipidemia means increase in the fat of in the blood. Hyperlipidemia, increase of fat in the blood. You can improve this by eating proper food, less fat in your diet. Hypertension, you can decrease your stress. Cigarette smoking, one can leave the cigarette smoking. Diabetes and all these are the modifiable, one can change them. So these are the two groups of risk factors of atherosclerosis. We all know about, we think that atherosclerosis is mainly caused by hypercholesterolemia. This is very common finding, our common understanding, our common belief that any person who has high cholesterol has high risk of atherosclerosis. There are different evidences, proof in the literature, but I must say that these are taken, this is mainly the lecture from the last year, and our book, pathology book, is about 6 years back. But now the evidence is against that. I cannot discuss the new evidence just now, but it's good to know the old story also. So we come to know that evidence number one is that when you look at the plaques, we look at the atherosclerosis plaques, the main thing inside is the fat. The lipids are inside, and most important lipid present in that center of the plaque is the cholesterol. So that is the reason they think that hypercholesterolemia, increase in the cholesterol in the blood, is the important evidence, important proof that cholesterol is the cause of the atherosclerosis. Then there are many genetic defects, diseases of the genes in which there is abnormalities of the lipoprotein metabolism. Lipoproteins are the important proteins which contain the fat and the protein. They are important because fat is not dissolved in water. You cannot dissolve fat in the water. So they can travel in the blood through the lipoproteins. They have to combine with the protein and then they circulate. So they are very important. We know about the HDL, LDL, high density lipoprotein, low density lipoprotein. So if there's abnormality in these lipoprotein metabolism, there will be hyperlipoproteinemia. When there's hyperlipoproteinemia, there's increased risk of atherosclerosis. The example is given here, very important condition called familial hypercholesterolemia. In this condition, there is defect in the receptors of these lipoproteins, LDL receptors. So in these patients, in these families, the patient can die at the age of 20 years. Sorry. So the myocardial infarction occurs in this patient in as early as 20 years of age. So this is a genetic defect in the receptors of lipoproteins. Evidence number 3 is that there are some diseases like diabetes mellitus, hypothyroidism. In that you can see hypercholesterolemia. Hypercholesterolemia is present in these diseases, and sorry, someone disturbed me in this office. So in diabetes and hyperthyroidism, there is increase in the cholesterol, and they also have increase in the atherosclerosis in such disease. So this is another evidence. And there is very important population study, done in America, from Framingham's study. This was an epidemiological study, a population study. They also proved that increased level of plasma cholesterol and LDH LDL will cause atherosclerosis. There was a correlation between these. So all these are the evidences that hypercholesteremia will cause atherosclerosis. But now it is changing. You will come to know later on. It's not the cholesterol, it is the lipoprotein problems. Nowadays, the new research is saying that. Now, there are many studies that there's decreased, these cholesterol can be decreased by various diets and drugs. And when you decrease the cholesterol by the diets or drugs, then atherosclerosis decreases, the plaques they decrease, and the risk of heart attack decrease. So these are all the evidences that hypercholesteremia can cause atherosclerosis. What is the mechanism? How can cholesterol cause atherosclerosis? There are two things. That whenever there's increase in the level of cholesterol, when there's chronic increase in the fat, that will affect the function of endothelial cells. They will impair the function of endothelial cells because of, we know this thing, reactive oxygen species. These are the oxygen radicals that are very strongly acting on different molecules. So whenever there's increase in the fat in the blood, they will affect the function of the endothelial cells, and that is through the reactive oxygen species. And nitric oxide, which is an important molecule produced by endothelial cells, the function of nitric oxide is it dilates the blood vessels. So when vessels are dilated, they function better. When they are constricted, they can cause hypertension, etc. So these reactive oxygen species will degrade the nitric oxide produced by endothelial cells. So this is one of the mechanisms which was the previous theory. Then they say that when these lipoproteins, they reach under the endothelium, they again are oxidized. They oxidize, they get oxidized by the action of reactive oxygen species. When they are oxidized, then the macrophages, we know the macrophages are the important cells. These are the defense cells of the body. So when these macrophages, they see these oxidized LDL, this is abnormal for them, they will eat them and become foam cells. They'll start eating the LDL and they become foam cells, and they'll become active. They produce growth factors, they produce inflammatory cytokines, they produce chemokines, and more cells will come. So again they said that the oxidized LDL is responsible for atherosclerosis. We saw in the picture previously, the diagram, that cholesterol crystals are present in the necrotic center of the plaque. So they are again like foreign body to the macrophages. Macrophages will think, where have they come from? So they are a danger signal for the macrophages, and they will start secreting the inflammatory markers like interleukin 1, interleukin 6, and other inflammatory molecules, and produce the atherosclerosis. This is just the mechanism. Again, there are many pictures from your textbook. This is a theory, again, an old theory which is no more effective now, that they said that the atherosclerosis occurs because there is chronic inflammation in the lumen and chronic inflammation of the endothelium, and that is why the changes occur. Our book, the textbook, has tried to explain on the basis of that. And due to injury, there is chronic inflammation of the endothelial cells, and this disease occurs. They give the number one step is that due to chronic endothelial injury, which can occur because of hyperlipidemia, because of the hypertension, because of smoking, because of this molecule called homocysteine, various toxins, viruses, etc., they are causing the injury to the endothelial cells. This is one of the theory which is now more effective now. So when this is injured, endothelial cells get injured, they become weak. Now they become improper, they cannot function properly, they cannot hold the molecules inside the lumen. Now the molecules, they will go out. the increased permeability. There's increase in the permeability of the endothelial cells. So you can see that they are coming out. The platelets are aggregating the monocyte macrophages. They will go out because of the increased permeability, leukocyte adhesion, monocyte adhesion, and migration. So because now the endothelial cells are weak, the cells and the lipids and everything will go out from the lumen into the intima of the blood vessel. And then in the third step, they said, when the macrophages, they go out, they get activated, and there is smooth muscle recruitment. The smooth muscles are present in the media, so they go up also because they form the cap of the plaque. So all these changes start occurring. The activation of the macrophages and lipids start getting collected, and the foamy macrophages are formed. So first step that can be seen grossly in this is fatty streak. Under the endothelium, you see all the foamy macrophages, the lymphocytes, and the crystals, etc. From the inside, you can see they appear as very small, very thin, fatty streaks, which are yellow in color. They are called fatty streaks. And finally, this plaque is formed. Now, this is the fibrofatty atheroma, because now the fibrous tissue and the smooth muscle cells, and this is the plaque has formed. This collagen is coming, lipid is there in the center, the necrotic center, the lymphocytes. So this is at the last stage. It is formed. A fibrofatty atheroma is formed due to response to the injury hypothesis. So these were the pathogenesis steps. Now, what are the stages of atherosclerosis? Whatever we have seen is the same. The first stage was yellow streak or fatty streak. Number 2 was the stable plaque, the main diagram it saw. It is stable because it has a fibrous cap, proper, strong fibrous cap, so it is stable. But after some time, when this becomes large in size, become unstable. And it becomes unstable, more and more fat is coming here, it becomes unstable plaque, and finally it becomes complicated plaque. You can see ulceration and hemorrhages. So there are 4 stages of atherosclerosis. First is the fatty streak, very small thing, then stable plaque, then unstable, then this is the stable plaque, then unstable plaque, and complicated plaque with hemorrhages and necrosis and ulceration. Histology, under the microscope, we see these clear spaces are the cholesterol. Cholesterol is a fat, so it does not take any color in the of the stain, so it will look white in color. This is the blood vessels, and this is the dark color is the calcium. And these are the inflammatory cells. We'll see more of them tomorrow in the practical. So this is the histology, high power at the junction of fibrous cap and the lipid core. Important thing to tell you is that stable plaque has fibrous cap is strong, more fibrous cap, very little fat in the center, and very little inflammation with under the microscope is stable plaque. The unstable plaque will more fat, very thin cap at the top, and there will be more inflammation. So that will be unstable. It will easily break down. Common sites, most important site is abdominal aorta under the renal arteries. Infrarenal part of the abdominal aorta is the most common site of atherosclerosis. Others are coronary arteries, popliteal artery. Anyone knows where is popliteal artery? You will do it in popliteal artery, number 3. I'm just asking to make a change in the disturbance. I'm continuously speaking, or maybe people are sleeping or not present. I thought let's ask you, what is popliteal artery?
Maybe
No one.
it's in the lower legs.
Yes, mashallah. It is behind the leg, behind the knee, in the leg, mashallah. Antral carotid and circular filus is also in the skull, base of the skull. So all these are the arteries where you can get atherosclerosis. But important point is that in one artery, any artery, you can feel all the pictures. You can find stable plaque, ulcerated plaque, complicated plaque. So in a single vessel, one may find lesions at various stages of severity. So all these can be present in one artery. So now coming to the clinical part. Now we are doing the clinico-pathological consequences. We have seen all the theory, we have also all the risk factors and the pathogenesis. You are sitting in the clinic, how the patient will look. Again, we have to correlate clinico-pathologically. So this part is the preclinical part. The second slide will be the clinical slide. So again, quickly, this is the normal artery. There's a fatty streak. The beginning thing, all these functions and monocytes and all these will come. Fatty streak, then fibrofatty plaque. And then when there's cell death, inflammation and growth, then it becomes advanced and vulnerable. You can see the lumen is small now. The lumen is becoming small. The blood flow will be decreasing. So this is the advanced plaque or the vulnerable plaque or unstable plaque. Now what happens? So from here, the clinical part starts. This is the clinical phase. From this advanced vulnerable plaque, three things can occur. Number one, aneurysm. What happens is that the wall of the blood vessel becomes weak and becomes like a balloon. It becomes like a balloon. Aneurysm means it becomes like a balloon. It projects out. There are many diagram picture will come in the later on. So that is called an aneurysm. This can rupture and cause more serious conditions. So one pathway is aneurysm. Second pathway is thrombosis. See, this plaque got advanced and ulcerated, and then thrombosis occur. Thrombosis is a different thing which we'll do just now. That in thrombosis there is clot formation and sudden blockage of the lumen, which can cause heart attack, etc. So number two is occlusion by thrombosis. Number three, slowly fibrosis occur, and the lumen becoming small and small, gradually. Progressive growth of the plaque is occurring. This will show as a chronic heart disease, a chronic heart failure. This will not cause heart attack, but it will cause slowly changes will occur. We'll see these more in detail in the second part. So this was about the clinico-pathological consequences. Either there will be formation of aneurysm, the formation of sudden blockage or occlusion by thrombosis, or there can be slow progressive critical stenosis. Major complications of atherosclerosis, there are many, of course, all over the body it affects, but summary, number one cause of the death in the population of the world, myocardial infarction, we call it heart attack. If this occurs in the brain, cerebral infarction, we call it stroke, then aortic aneurysm, and then again, if there's problem in the blood vessels of the legs, etc., the legs can get gangrene. Gangrene means death of the soft tissue of the extremities, blood vessels of the lower limb, etc. Then these are the important major complication of atherosclerosis. Number one, myocardial infarction. Number two, cerebral infarction. Number three, aortic aneurysm. Number four is gangrene of the extremities. So this was about the atherosclerosis. We have completed the first part of the lecture. The second part is the myocardial infarction. Myocardial infarction or heart attack is a type of ischemic heart disease. So ischemic heart disease is different than myocardial infarction. Myocardial infarction is just a type of ischemic heart disease. So what is ischemic heart disease? Ischemia means decrease in the blood supply. Myocardial ischemia is, or ischemia generally decrease in the blood supply to any part of the body. So whenever there's myocardial ischemia, there's imbalance, there's disturbance of the balance. The supply to the heart is less, perfusion is less, and the demand of the heart is more. The heart is working more, it needs more oxygen nutrition, but the blood supply is less. So there's a disturbance and there's decrease in the blood supply. We call it myocardial ischemia. This can occur due to, again, we saw this thrombosis. This can occur also because of this critical stenosis. So there are different types of myocardial ischemia. Myocardial infarction is just one of the syndrome. The other are angina pectoris, chronic ischemic heart disease, heart failure, sudden cardiac death, all can occur because of the ischemia. So ischemia is a general thing. In that, there are many other diseases. I give you the example of angina pectoris. Angina pectoris is when person is sitting, lying down, resting is okay. But when he starts walking, the heart needs more blood. And because of this stenosis, more blood cannot come to the heart and the patient will start having pain in the heart, in the chest. Angina pectoris means pain in the chest. Or he can have dyspnea and problem. Similarly, all these conditions can occur when there's decrease in the blood supply to the heart. All these are called ischemic heart disease. And in 90% of the cases, more than 90% of cases, atherosclerosis is the cause of ischemic heart disease. This is a very good diagram from your book, and it again tries to explain. The diagrams are good to understand. This is the normal after atherosclerosis. This is the simple thing. A little bit about half of the lumen is blocked. About half is blocked by this stable plaque, and you can see patient will get angina. At rest, he is okay, but when he starts to walk or he needs more oxygen, the heart needs more oxygen, he will have pain in the chest. This is called angina pectoris. What happens after that? After some times, you see this becomes irregular and platelets will come and aggregate here. This is called plaque disruption. Now platelets get and aggregated. In the beginning, they can just heal slowly, and like this, it can just slowly healing and lumen becomes smaller, and this is called severe fixed coronary obstruction. In this condition, the patient will develop chronic ischemic heart disease or heart failure, slowly and slowly, gradually. There's no heart attack in this stage. This will occur in this stage. We'll see the next slide. When this platelet aggregation and plaque disruption occurs, thrombosis will occur. Then the next step is aggregation, thrombosis occurs. Thrombosis of two types. Mural means only in the wall, not completely blocking, and occlusive means complete blockage of the lumen. Thrombosis is suddenly there is clotting system starts. We'll do more about it. So thrombosis occurs. There'll be mural thrombosis. Mural means in the wall, only in the wall. The remaining is open. So there's partial obstruction, variable partial obstruction. This will cause all these conditions called unstable angina, acute subendocardial myocardial infarction, little bit infarction only under the endothelium, and sudden death can occur if they break and block another plaque. That is called embolism. We'll do that also. When this thrombus detached from this origin, and it will go to the another part of the body and block there, and then can cause sudden death also. But suppose the thrombosis is severe, it will block the complete lumen of the blood vessel, then there will be acute transmural myocardial infarction. Acute, we understand what is acute, sudden. Transmural means the whole wall of the heart is affected, transmural. Myocardial infarction occurs or death can occur if there's thrombosis and sudden blockage, and occlusive thrombosis occurs. So these are the acute coronary syndromes. Whenever there's thrombosis, there's acute coronary syndromes. So now we are coming to myocardial infarction proper, when there's complete blockage of the lumen due to thrombosis, due to thrombus formation. What is infarction? Infarction is necrosis of the heart cell, heart muscle due to ischemia. Necrosis of the heart muscle due to ischemia is called myocardial infarction. Necrosis is the term we use when we see under the microscope. Infarction is the term we use when we see it with the gross naked eye. So this is the difference. They are the same things. If we are looking at the cells which are dead, we call them necrosis. We are looking at the under the post-mortem. When we do the post-mortem, we see, oh, this is grossly, you are not doing microscopy, you see, we call it infarction. And everyone call it heart attack. The clinicians, everyone call it heart attack. So this is just new, different terms. This can occur at any age, even before 40 years of age. I've done postmortems in UK. They were 30-year-old have also developed these myocardial infarctions. Very common, becoming more common, but most occur after old age. Black race and white races are equally affected. Men are greater risk at women of reproductive age. So ischemic heart disease is the common cause of death in the older menopausal. So when they become menopausal, they become postmenopausal, then the risk is same. So it's one of the common cause of death in the older women also. Pathogenesis, you'll get bored again. Just quickly we'll go through. The main cause is, of course, of myocardial infarction is acute thrombosis, sudden blockage of the coronary arteries. When there's already a plaque which gets disrupted and there's thrombosis, it occurs in 90% of the cases. Sometimes there's no thrombosis. The blood vessels get spasm, that get contracted, or there's embolism in 10% of the cases. Sometimes there is a plaque plus there is excessive demand. The patient is weak, the patient has the problem, patient has this thing, but suddenly he starts to walk, he wants to run, he develops other diseases, then also there'll be. Sorry, anyone speaking? Okay, maybe by mistake. So these are the different methods by which myocardial infarction can occur, but in 90% of cases, it is thrombosis. Grossly, if you look at this picture, this is a slice of the postmortem heart. The patient has died. They put a stain, not always, we never used to put it. They were most of the time present, but sometimes to teaching purposes, they put different solutions. Here you can see by putting the solution, this becomes yellow in color. So this is the infarcted area because of the TTC, triphenyl tetrazolium chloride staining. So this become clear now that this is infarction. And you can see this is yellow in color, not because of fat, because of the staining reason. And then this white is different from this yellow. These are the old infarct. These are the old infarcts. And here, this is dark blackish in color because here the heart wall was ruptured because this was transmural, full thickness of the wall of the heart was affected, transmural, and here the heart wall was broken, there was rupture, and he died suddenly because of the rupture of the heart. There's blackness because of the hemorrhage here. So it's the gross picture of the slice of the acute myocardial infarction. Under the microscope, we call it necrosis. Again, necrosis of 4 types, many types, which we'll see tomorrow, inshallah, in the practicals. So necrosis, this here, which is the coagulative necrosis. I will not go into detail because it's already long. So in the after necrosis, there's acute inflammation. You see neutrophils. And then we go, after some time, we get chronic inflammation and healing starts. And finally, this is a special stain showing blue color fibrosis. This is a special stain showing the fibrosis in the heart. So all these stages, we'll see more tomorrow, inshallah. Clinically, the most classical feature is severe crushing chest pain or pressure. Some people also call it, you will laugh, but it is a serious thing that people say that elephant sat on my chest. They said it is so severe, it feels like the elephant is sitting on my chest. It is heart attack pains are like this. It's very severe pain, crushing pain in the chest. It radiates. When you do in the third year, you will come to know what is radiation of the nerve supply and pains. So it radiates to the neck, it goes to the jaw, it goes to the epigastrium, to the left arm. So these are the typical features of myocardial infarction pain. It remains for many minutes and hours. You know, in angina, when the patient rests, he becomes okay, or he is given a tablet called nitroglycerin under the tongue. This is a vasodilator, then the patient becomes okay. So if there's myocardial infarction, patient will be not relieved by resting or by not relieved by nitroglycerin. So this myocardial infarction pain is not relieved by these two things. Angina pectoris pain is relieved by these two things. That is why it has been written here. Other clinical features are atypical. Sometimes in old persons or in patients with diabetes, there's no symptom, no pain. They may die suddenly. When you do the postmortem, you come to know that the patient had heart attack or myocardial infarction. So they are entirely asymptomatic if they are diabetic or they are old patients. Sometimes they get only rapid and weak pulse. They get sweating, which we call diaphoresis. Patient is diaphoretic. They're sweating. There's dyspnea. You know what is dyspnea? I hope you all know what is dyspnea. Difficulty and in breathing. Okay, mashallah. So difficulty in breathing, breathlessness, shortness of breath. The nausea, we all know, this is the lady having nausea just before the vomiting. Complications is just a list. I'll just quickly go through because this is nothing to explain. Cardiogenic shock is the most common, and all these are the list of complications of myocardial infarction. Now we come to the third part. Any questions up till now? I don't know if I've been always get a complaint that Dr. Akbar speaks very fast. If you have any complaint, let me know. Okay.
No,
Yes?
It's clear, doctor.
Thank you so much. Thank you very much. Okay, now come to the last part of this lecture, is the thrombosis. In this, you can see this the blood vessel with this all this yellow thing is the plaque, and here in the center you see this thing. In the lumen, this is the thrombus. So the definition of thrombosis is this is the process of formation of a solid mass called thrombus. How is it formed? From the blood constituents. It formed from the blood material, whatever we know, the clotting systems. Tomorrow you will have all these lectures of clotting and hemostasis, etc. So these are formed from the blood constituents, the RBCs, the WBCs, the fibrin, etc. Within the wall, within the lumen of the blood vessels or within the heart. So it is the process of formation of solid mass. The solid mass is called thrombus from the blood constituents within the blood vessels or within the heart. So this is thrombosis. There is a very famous word used is Virchow's triad. Virchow's triads. Virchow was a German pathologist. He was known as father of medicine and pope of pathology. So he first discovered this, that thrombosis occurs due to three things, three factors. Number one, endothelial injury, injury to the blood vessel, abnormal blood flow, either it becomes slow or irregular, and third, changes in the constituents, the coagulation changes, hypercoagulability. The blood has the property to quickly coagulate. So these are the three factors called Virchow's triad. These are three primary predisposing factors. So how endothelial injury can cause thrombosis? Whenever the endothelium lining is irregular because of the atherosclerosis, because of the valves of the heart are diseased, because of the hypertension, because whenever there is hypertension, the endothelial cells are injured because of continuous high pressure, there is injury to the endothelium. So these are the causes of endothelial injury. So when there is injury to the endothelial cells, the platelets in the circulation, they will come and get attached to that damaged surface. They release all these factors, which you'll do tomorrow, hopefully, all the thromboplastin, all these factors of clotting, and the coagulation is activated and thrombosis is formed. So this is the atherosclerosis, yellowish in color, and that this is the clot. The dark color is the thrombus. So this is how endothelial injury is done by atherosclerosis, diseased valves, hypertension, and then platelet will come and cause coagulation and thrombosis. Blood flow is affected in two ways. Either the flow becomes slow, the blood flow becomes slow, or it is turbulent. This is slow. Suppose it is normal. We cannot say normally it is fast in the center and periphery, but this is turbulence. You see, because of irregularity, because of the atheroma inside, so there's irregularity. So this is turbulence. So when there's ulcerated atheroma, there's turbulence. When there's aneurysm, see, these are aneurysm. When the wall of the aorta or the heart becomes weak, they become balloon-like. They become balloon. There are two types of aneurysms here. One is fusiform, the other is secular form, and they can rupture also. So these are aneurysms. So in the aneurysm, the blood is stasis. It's not moving. So when it's not moving, it is slow, then thrombosis can occur. Or patient has some other problem, like he has a fracture of something, he's on the bed rest for a long time, he is not doing any muscular activity, then there'll be slowing of the blood and there'll be thrombosis. Even in the long flights, you know that if there are long flights, they ask you to move around after a few hours, that otherwise you can get the thrombosis in the legs, the veins, because the muscles in the leg are called peripheral hearts. The muscle of the calf, muscles, because when we walk, they pump the blood up. So if you sit for a long time, then the blood will be stasis and you can get thrombosis. So this is the reason they ask you to move around in the long flights in the airplanes. And if someone is on the bed rest, they should be moving around, otherwise they get thrombosis. And this thrombus will get moving upward and can reach the heart and the lungs and cause infarction. Finally, alteration of blood constituents. Hypercoagulability. Coagulability means the blood has the property to clot quickly, fast, hypercoagulation. It can be due to genetic problem or due to acquired problems. Genetic disorders like mutations in factor V, prothrombin genes, etc. There'll be property of the blood to coagulate quickly and fast. Or there are patient having smoking, obesity, burns, severe trauma, shock. They also get the property that the blood clots quickly. So this is the third part of the Virchow triad. What are the types of thrombus? We know if the heart is a big structure, aorta is a big structure, so the clotting or the thrombus attached to the wall only. So there's a mural thrombi. It cannot fill the whole heart. It will not fill the whole heart. It will be just in the wall. So it is mural thrombi. It is seen in the heart chambers and the aorta because they are big structures. But suppose they are in the valves, on the surface of the valve, heart valve, they have got the name of vegetations, like vegetables. So they are called vegetation if they are only in the heart valves. Just the change of the name. So this is the mural thrombus in the ventricle. Otherwise, it's only in the part. It's in the part of the wall. This is the aorta which has been opened. So you see this is atherosclerosis and this was the aneurysm. This has ballooned out. And here the clot or the thrombus is formed and is layering. Because of flow, it forms layer. These layers are called lines of Zahn. So you can see this clot has layers in it. So there's lines in it, lines of Zahn. So this is the aorta, which has an aneurysm. And because the blood is not flowing properly, it will become thrombosis with these lines. The third type, the second type of thrombus is occlusive. When the thrombus occurs in the small blood vessels, small arteries of the heart or the brain, anywhere, because the artery is small, it will occlude, it will block it. So they are called occlusive thrombi. They will completely block the lumen of the blood vessels. So first type was bural, second type was occlusive. Third type is venous. The venous thrombi are mainly of two types. One are the legs. We know just now I told you about the blood can get clotted in the legs and in the they cause varicose veins. These are the irregular thickened veins. These are varicose veins. And inside also, this is the clot in the muscle. This is the skeleton muscle of the legs. The second common site of venous thrombus is in the skull. In the skull, we have these sinuses. These sinuses, maxillary sinuses and the venous sinuses can get also thrombosis, and patient will come with all these symptoms. You can see this redness, etc. is because of the thrombosis in the sinus. This is because of the infection. When there's infection, there is inflammation, then these sinuses can get thrombosis and patient can get all these picture. So third type is venous thrombi. What happens to the thrombus? What is the fate of the thrombus? Sometimes the thrombus becomes completely normal. This is resolution. We call it resolution when the thrombus becomes completely dissolved and becomes normal. The lumen becomes open. This is called resolution. Number two is embolism, means the thrombus gets detached. Some part of this thrombus get detached, usually from, suppose, in the veins, then they come up from the veins into the inferior vena cava and to the right side of the heart, through the pulmonary circulation, and to cause pulmonary embolism if they are coming from the venous side. If it is in the heart, they can get detached from the heart, they go into the arteries, and they can block the smaller arteries of the brain or any other part of the body like spleen or kidneys and cause infarction. So that is called embolism. When we'll do embolism also just now. So they get detached, some part of the thrombus get detached and circulate in the circulation to reach other parts and cause, as I think you have done the neoplasia, etc. You know the metastasis. So it is less like that. So it's a baby of thrombus, which is now going into the circulation causing infarction. Third type is organization and incorporation of the wall. Sometimes the thrombus get fibrosed, organized, and it is just incorporated in the wall. It gets hidden and the endothelium comes above it. That is called organization and incorporation. This is the third type. And finally, organization and recanalization. If suppose it is large, it gets organized and small lumens are formed. See, these three small lumens are formed in this. This is called recanalization. So this is number 4, recanalization. And finally, propagation. Sometimes they just keep on growing inside the lumen towards the heart. So they are propagation. They grow forward inside the lumen. This is very rarely occurring, depending on the original cause of the thrombus. This can occur. Propagation means it keeps on blocking the lumen and going forward, just like you see when there's flooding, when after raining the water flows, so in the wadi or in the valley. So similarly, they also keep growing. This is called propagation. Finally, quickly we'll go through the definition of embolism. Embolus, yes.
Can you explain embolism again?
Embolism or thrombosis?
No, embolism.
We are starting embolism now. Okay. Yeah, because that was just a quick. So now we have few slides of embolism. When this thrombus is formed, some part it breaks down. It breaks down, get detached from the thrombus and goes into the circulation and get attached and reach another part of the body. That is embolism. The definition is embolus is an abnormal, undissolved mass. It can be solid, it can be liquid, it can be gas and carried by the bloodstream. Is it clear? So it can be, first mainly it is 95% is thromboembolism, means a thrombus which is formed in the vessel. It breaks down. Some part of the thrombus breaks down, and that is also a small solid mass. Then it will circulate in the flow. It will go into the blood circulation. If it is in the vein, suppose it is in the vein of the leg, if it is breaks down, it will go up through the inferior vena cava to reach the right side of the heart, into right atrium, right ventricle, and then it will go into the pulmonary artery, and then it will block there. So it will cause pulmonary embolism. So I gave you the example. If there's a thrombosis in the legs, some part of that thrombus, that big clot, breaks down and starts circulating in the circulation. From the veins of the legs, it will come up into the vena cava, into the right side of the heart, and reach the lungs. Because the lungs have capillaries, so they will block there. They cannot go from the lung back into the left side because they will block the capillaries and cause infarction in the lung, right? So this is the commonest type, thromboembolism. There are three other types. We'll do that.
Doctor?
Yes.
The difference between the embolism and thrombus, is it that the thrombus is constant and the embolism is at moving by the bloodstream?
Yes.
Is that the difference?
Yes. Thrombus is the fixed thing. It is there, fixed and blocking it. That's like a father or the big one. From that one part break down, and it starts circulation. Like in the park, you have mother and father and the baby. The baby just runs away and goes away in the park somewhere else with other people. So it will go into the circulation now. The main thrombus remains there. Thrombus has our other fate. I told you it remains there, it gets incorporated, it gets resolved. But if there's thrombus in that stable, it is there, some part break down. Suppose my arm, my hand breaks down and goes away. It falls on the ground. So that is, the hand is now an embolus. So similarly, embolus goes into the circulation and reach another part of the body because of the bloodstream. Is it clear now?
Yes,
Okay.
it's clear. Thank you.
So mainly it is solid, and mainly 95% comes from the thromboembolism. But there are other embolism also. Fat embolism, air embolism, and amniotic fluid embolism. I hope you all know what is amniotic fluid. When the
Yes.
Yes, in fetus.
you have done all this. I think there were cases. I remember you have all these pregnancies and everything. So sometimes in the difficult labor, the amniotic fluid can enter the blood circulation and cause embolism. We'll see the pictures now. So the most important is thromboembolism. It can be on the arterial side. They come from the mural thrombi on the heart, from the aortic aneurysm, and sometimes we don't know from where they are coming. Here I must tell you, one is paradoxical emboli. I just gave you the example 2 times that a thrombus, an embolus which starts from the leg, it will go up in the inferior vena cava, it will go to the right side of the heart. See here, this is the inferior vena cava, it comes from the right atrium, right ventricle, and go to the lung, okay? And then it blocks here, cause lung infarction. But sometimes what happens, there's a defect in the heart. There is patent foramen ovale, or there's ventricle septal defect. So from here, it will jump to this side. It will come, see here, it is coming from this side. From the right side of the heart, it goes to the left side of the heart because of the defect in the septums, the atrial septum or the ventricular septum. So now an embolus which was supposed to go to the lung is paradoxical. Now it's going back into the arteries. So that is called paradoxical embolus. It is very rare. A venous embolus passing through atrial or ventricular septal defect into the arterial circulation, and then they cause infarction on the arterial side. Is it clear? So patient, this very rarely, paradoxical means abnormal, not normal. Paradoxical is just a general term, is English word, English language word, paradoxical. So because of the defect in the septum, they jump from the right side into the left side, and then they go into the artery. They don't go into the lungs. So this is paradoxical. Venous emboli, I just told you, they come from the deep veins of the leg. They dislodge, they break down, pass through the right atrium and ventricle to go to the lungs and cause pulmonary embolism. In the lungs, there is difficult situation. In the lungs, if they are small emboli, they can produce pulmonary infarction and pulmonary hemorrhages if they are small in size. When they reach the lung, they will cause either infarction or hemorrhages. But if they are large, see, this is a large embolus which is called saddle embolus. When they enter the pulmonary artery, they can block the bifurcation of pulmonary artery. It's like a saddle is blocking it. And when this does this, it will cause sudden death because now circulation has stopped suddenly. So patient can die suddenly because of this saddle embolus. It's a large embolus coming from the vein of the leg. When it reaches the pulmonary trunk, it blocks the bifurcation of the pulmonary trunk like a saddle of the horse. It is called a saddle embolus or saddle emboli and can cause sudden death. Okay? Fat embolism or marrow embolism occur when there's fracture of the bones or there's fracture or soft tissue injury, trauma. Then the fat and the bone marrow can go into the circulation and block in the lungs, into the brain, into the kidney, etc. And they can cause syndrome. I forgot, leave this, it will be too much for you. Just remember, fat embolism or bone marrow embolism occur due to injuries and fractures. This is the picture of the fat marrow embolism. You can see this is the bone marrow with fat and this marrow element in the circulation. This is the lung tissue and it's reached the lung. So this is the bone marrow embolism. Air embolism can also occur. We know the chest, our chest, the thorax, has negative pressure. If there's injury to the chest, then air can go into the large veins of the chest and the lungs, etc. And sometimes even in the leg injury, air can go inside the veins and then they can go into the circulation. These are the air in the circulation in the veins, and they can cause sudden death also. If there's large, there should be at least 100 millimeters to cause clinical features, clinical symptoms. Air can go into the circulation and then can circulate. That's like air bubble in the water supply, you know, air bubbles can cause damage and they block the water flow. So similarly, these can also circulate in the circulation, reach the lungs and can cause sudden death also if they are large in quantity. But if it is less than 100, sorry, if it is less than 100 milliliters, then there's no symptoms. Here again, I must tell you again another interesting disease called Caisson's disease. This occurs in the deep sea divers. So when the deep sea divers, they go inside, they breathe at a high pressure. So the nitrogen dissolved in the plasma under the high pressure forms numerous small gas emboli. When the person comes out rapidly, the diver, when they come out rapidly, they can develop gas embolism because of the nitrogen becomes bubble. It's called decompression sickness or Caisson's disease. Finally, amniotic fluid embolism. This occurs when there's prolonged labor during the delivery. It is prolonged, or there's trauma during delivery. It is a rare condition, but when it occurs, the mortality, the death rate is very high. So you can see this, again, this is the lung tissue. And this is the blood vessel showing squams. The amniotic fluid, you know, contains the skin, the stratified squamous epithelium of the baby, of the fetus. So this has come into the circulation of the mother. So this is the amniotic fluid embolism. So it comes from the uterus, from the placenta into the circulation, reach the lung and cause amniotic fluid embolism. I think that's all. Alhamdulillah, we completed in 1 hour. That's 3 lectures. Okay, tomorrow, who's the leaders here? Yusuf, Jamil? I must tell you, tomorrow we have, I have a session with my own group of 3rd year from 1 to 3. And I can take the practical from 3 onward, 3 p.m., okay? So these are extra things of, you know, year 2. I'm a year 3 tutor. And tomorrow I have session with year 3 students, my own group, PBL students. So from 1 to 3. So I will start the practical inshallah at 3 p.m. tomorrow. Okay, any questions you can send me by WhatsApp. I know, mashallah, you are good when you read and then you can send questions. And I will try to send the slide, the file of the practical tomorrow morning because I'm already very busy. And there's something extra I have to work hard and make according to my own interest because it's very difficult to teach from someone else's file. I cannot teach. So this is what I did from my own files, made many changes in this. I hope it is okay according to the objectives of your course. Okay, ma salam.
Doctor, can I ask you a question?
Yes, please.
In the preclinical phase of atherosclerosis, is it reversible?
You see, there are trials going on. Say, if you go through my lectures, in one of the Dalil in the evidences number 5, I said that through the drugs and the lifestyle, they can be reversed. But it's very rarely, very few. There are cases, there are recent reports that if you eat only plant food from the plants, because cholesterol is in the animals, it is not in the plants. So there was two good studies in which they did the X-rays of the heart that's called coronary angiography. They showed that after a few months or few years, the atherosclerosis was reversed in the heart. This was a doctor, a young doctor of 40 years. He did it, and he did not eat any plant food, no milk, no egg, no meat, anything. So only on plants, no oils also, he was reversed. So it is possible, but very rare. It's very difficult. I also tried I have family history of cholesterol, so but it's very difficult to restrict all these things. It's possible, yes. Now the drugs are coming, more and more drugs are coming. These days, in my own interest, you must have heard of pathologists, gastroenterologists, etc. You come to know that there's a lot of lipidologists now. They are very new specialty called lipidologists. They just treat the cholesterol. So they are possible, of course. You are right. Thank you very much. Yes?
What is the difference between gangrene and necrosis according to the pathogenesis?
Okay, necrosis is a journal term. I think there are some slides tomorrow also. Necrosis is death of tissue, which you see under the microscope, is the word used. Then there are many types, like coagulative necrosis, which occurs in the heart, in the kidneys, coagulative necrosis. Liquefactive necrosis occurs in the brain, or abscess, when there's pus formation, it liquefies, that is liquefactive necrosis. Then there's caseation necrosis, which occurs in TB. It is called caseation because it looks like a cheese, like jubna. So it is called cheese-like necrosis. Then there we have this gangrenous, which becomes black because of the special bacteria. So necrosis is a journal thing, and there are types. Gangrene is a type of necrosis, okay? You can ask these questions, inshallah. Tomorrow we'll have a slide of types of necrosis also, inshallah. Any other question?
No, thank you.
Okay,
Can I
masala.
ask a question?
Yes?
What is the main factor that increase the viscosity of blood?
They are divided into two groups. One is the genetic disorders, which increase the viscosity, and the other are the acquired ones like smoking, even burns. You see, when someone is burned, a lot of dehydration occurs, the blood becomes more viscous, and all these types, you see the list I've given you in that slide. They can increase the coagulativities. Tomorrow, I think you have Dr. Maher is taking some of these lectures on coagulation. There are 2 lectures tomorrow. You can ask them more specific questions. They are the specialists. Okay?
Okay, thank you.
Welcome. Okay, ma salam.
Assalam.